This video will demonstrate the extended retrosigmoid craniotomy and macrovascular decompression of the left V4 vertebral artery for brainstem compression. The patient was in his 70s. He presented with staccato speech, dysarthria, and severe dysphonia. His symptoms were progressive over many years. On exam, he had marked dysarthric and dysphonic speech. The remainder of his exam was normal. These T2-weighted MR images demonstrate how the left vertebral artery burrows its way into the middle cerebellar peduncle of the pons. The 7th and 8th nerves are pushed up into the brainstem by this loop. This pathologic knuckle is also shown here on these moving images of the MRI and CT angiogram. These illustrations show the supine patient position and the craniotomy. Surgical strategy consisted of a left extended retrosigmoid craniotomy, dissection of the petrosal fissure, opening of the glossopharyngeal cochlear triangle to expose the V4 vertebral artery loop, following the compressive loop to release arachnoid adhesions, placement of the Gore-Tex V4 sling, creation of a dural sleeve in the dura of the petrous face near the endolymphatic sac, anteromedial and inferior transposition of V4 using the Gore-Tex sling, tightening and securing the sling with an aneurysm clip, and finally placement of Teflon pledges between the right vertebral artery and the vagus nerve. Here's an overview of the surgical exposure. The top of the head is to your right, the feet are to your left, and the sigmoid sinus is at the top of your screen. Here is a view into the cerebellopontine angle cistern, where I'm dissecting the 9th and 10th nerves away from the cerebellum. The arachnoid of the cerebellopontine angle cistern is opened further around the 7th and 8th nerves. Here you can see a loop of ICA diving into the petrosal fissure. This is the 7th and 8th nerve bundle. Here the vertebrobasilar junction is pulled away from the pons and the middle cerebellar peduncle. In order to get additional exposure, I'm opening here the petrosal fissure. There's thickened arachnoid over the fissure, and you can see these different branches of ICA filling up that petrosal fissure. Additional dissection down by the 9th and 10th nerves gains additional freedom into the cerebellopontine angle cistern. Here now that loop of the V4 segment is pulled forward. This releases it from its knuckling into the pons. I've placed a cottonoid behind it to hold it forward. Now I can slide a sleeve of Gore-Tex around this V4 segment. I'm passing the slit end first, which you can see here now wrapped around the artery. I've cut a small pointed end on the opposite side, which is fed through the slit. By passing it through, we form this lasso that grabs the vertebral artery. The lasso now becomes a single-armed lasso that can be fixated to the clival dura with a clip. Normally, I secure the lasso here in the lateral clival dura, but the dura is very thin. Therefore, I'm transitioning to thicker dura more laterally. Here you can see those folds of dura right near the endolymphatic sac. These provide a nice, strong anchor for the anterior blade of that aneurysm clip. The posterior blade goes around the lasso, and together it holds the tail against the clival dura. With inspection, I'm concerned with the stenosis of that V4 segment. Therefore, I'm going to release the clip and slacken the tension just ever so slightly, and this looks better. Now you can see how that loop of V4 is pulled out of the brainstem and forward, and icy green video angiography confirms patency of flow within that artery. So the ipsilateral V4 segment is nicely mobilized, but you can see how the contralateral V4 is still compressive into the 9th and 10th nerves. Therefore, I push the artery more medially, and I'm placing this Teflon pledget between that artery and the 9th and 10th cranial nerves. Now there is no contact from the right V4 segment on these nerves, and fibrin glue anchors that Teflon pledget. Here is our final construct. These illustrations show the sling technique. You can see the pathology in the lower left. You can see the creation of that sling with the slit and the pointed end. And then you can see to the lower right how the dural pocket and the aneurysm clip create a pulley to anchor the tail of the lasso and transpose the vertebral artery forward. This construct creates a vector that pulls the artery away from the brainstem. The patient tolerated the procedure well. He had a mild House-Brackman grade 2 facial nerve weakness, which resolved within 48 hours. His dysarthric speech improved noticeably. The patient was discharged home after a short hospital stay. In conclusion, chronic pulsation of vertebral artery dolichoectasia can cause cranial nerve and brainstem compression syndromes that are not responsive to Teflon pledgets and standard microvascular decompression. Macrovascular decompression transposes the offending artery off of the brainstem and nerves with a sling and aneurysm clip. The sling should pull the artery forward and medially away from the nerve and/or brainstem and toward the clivus or adjacent petrous face. The use of an aneurysm clip enables the tension on the sling to be adjusted or fine-tuned with care not to stenose or occlude the artery or its perforators. Thank you.